Good afternoon, folks. This is Rob Ray, CEO of BlueStar. I'm in an undisclosed location away from the office right now, as you can tell by the ceiling fan. And today is the first of our weekly FAQ webinar sessions. And we have about 17 attendees right now. So thank you for that. I'm going to share my screen and go through some PowerPoint quickly. And then we can talk about whatever you want. If you have questions, go to the bottom of your screen and there'll be a button that says Q&A and just ask the question. And you can ask it just of the panelists, which is me, or you can ask it so that everyone can see it. And then I will call that up. And when I'm done with the PowerPoint questions that we'll go through, then I'll answer any questions that you might have. We have everybody muted right now. And so it makes it easier that way. And we can put out this information. And if there's anything you need to talk about individually when we're done here, happy to do it outside this call because we're up over 20 attendees right now. Okay, so I'm going to share my screen and go there and go there. All right. So we'll talk a little bit about answering some questions. And I have a brief update, and then we'll go through some FAQ of people that have already asked me, and then we'll have any other questions that you folks might have we can go over. Again, this is being recorded and will be posted later on so that you can get to it, or for those of you that aren't here, you can get to it. I want to try to do this every week, Tuesdays at 1 o'clock, and that we'll permanently post them so that you'll be able to go back and look at any time. I'm also going to try to send an email update to everybody on Friday afternoons so that a couple times a week you'll be hearing from us at BlueStar TeleHealth, whether or not you want to. In the meantime, be aware that we post things to bluestartelehealth.com/sales. That's salesy kind of stuff for the sales team. And then bluestartelehealth.com/ops. And that's things that clients need. And there's also some things that you should look out there. There's FAQ for clients, which you might want to know so that when clients ask you those questions, and there's forms, and we just uploaded a bunch of new things this week, patient information forms, which those of you that are familiar with VitalTech, they'll look very familiar because they were a spin-off or a modification of the VitalTech forms, which work great. And then lastly, I wanted to mention our onboarding procedure. We start with an LOI, which is that one-page letter of intent that we talked about. And as soon as that's signed, then we FedEx a 3-ring notebook, which is about that thick, that has all the forms and all the information that a client might need to get onboarded. And then we have a kickoff meeting. And we went through that, the dossier, the 3-ring binder. And so it's a great way to get going. And then at that kickoff meeting, the client can say, yeah, I want to use typical 4 weeks to get on board, or I'd rather do it faster, or I'd rather do it slower. And then our account manager sets up a schedule to knock through all the items on the to-do list so that we're done in the number of weeks that the client wants to be done on. So we have 2-3 account managers available at any given time. And so we have plenty of opportunity to bring on new clients. Okay. I'm going to go into some questions, and these are all questions that have been asked of me in the past week. So I just wrote them down on PowerPoint. I'm going to give you the answers. And then as you get more questions, remember to go to the question box and type it in. Someone said, what email signature should I use? My answer is you can make your email signature be whatever you want. You can say that you're an authorized representative for BlueStar TeleHealth if you want. You can stick in what other information you want. If you want to use our 800 number, you can, but you might be better off using your own cell phone number. And on the right-hand side, you can see what I put in my signature. I may have too much information in my signature, but I'd rather give people more information than less. Next question. Someone said, will we have visibility into the growth of patients at our client accounts? And the answer is yes, absolutely. We want you to see what's going on. And we'll send you a monthly statement of activity that'll show who your clients are that we're currently servicing, how many patients they have, how much they paid the previous month, and what your share of that revenue is. If you sign up Dr. Smith's office, we want you to stay in touch with Dr. Smith because we want you to see what's going on there. And if Dr. Smith hasn't brought on any new RPM patients in the last 3 months, then we want you to be involved in helping Dr. Smith to do that. I get asked this question a lot. What's the best kind of physician to target? I basically say folks who have Medicare patients, folks who have patients have chronic conditions such as hypertension, diabetes, obesity, COPD, CH. And so those tend to be GPs, general practitioners, internists, geriatricians, cardiologists. Almost all doctors have Medicare patients. You don't want to, for RPM, work with podiatrists or dentists or probably orthopedic surgeons, neurologists. I had another question which I didn't write here, and that is there any kind of RPM for behavioral health? And we are unaware of any devices that can measure behavioral health. We can measure activities of daily living, such as how many times someone left their bed or went to the bathroom or opened the refrigerator door. And one can make inferences on behavioral health from that, but it's not really behavioral health. Next question, someone said, what size practice is too small? And I say, we're not going to turn away even a small practice. If you have one doctor who has, a few hundred patients and they might be 20 Medicare patients that need this, then we'll take care of them. On the other hand, it's almost the same amount of work to bring on a one-person practice as to bring on a 5 or a 10 clinician practice. So when in doubt, if you want to practice on small practices, no pun intended, that's great. But if you want to invest your time getting somebody to sign up, try to sign up a larger practice. A couple of people have said, should we target nursing homes? And this is not a completely unofficial answer. And maybe at the end of this, we'll have I'll ask Mark Iavino if he has any comments or questions on any of these, because Mark has been doing this for some time and is our resident expert, not in nursing homes, but in selling this product. Generally, RPM is designed so that when you have a patient over here and a doctor over here, and the doctor wants to manage that patient, okay? Most nursing homes, the patient is already being cared for in some fashion. There might be nurses or nurse assistants in the room every day. The doctor might be on site. So those aren't really applicable for the kind of RPM that we are selling. Now, there are some nursing homes where there are no doctors on site and there's no medical care being provided on site, and those might be appropriate, but those aren't the normal nursing homes that I'm used to. So I guess I would say, even though it's true there are a lot of Medicare patients at nursing homes, that this RPM might not be a fit under most conditions. Next question. What question should we ask the doctor when we first get him or her on the phone? I always say it's pretty simple. It's 2 questions and you can almost skip the first one. Do you have Medicare patients? Almost all doctors, unless you're doing adolescent dermatology or something, almost all doctors have Medicare patients. And then I say, Doc, are you doing remote patient monitoring at your practice? And if they say yes, then ask, how's it going? And if it's going great, say, God bless you. How are you doing that? Who are you doing it with? Learn more. If they say, no, it sucks and it's horrible and I hate it, then say, well, how could we help you to make it better? And then if the doctor says, no, we don't have RPM in our practice, then just say, hey, would you be willing to spend 15 minutes on the phone with Admiral Ray and me, and we can talk about whether or not it's something that might be a fit for you? And you'll find out. Doctors either have it or they don't have it. And if they don't have it, they either want to talk about it or not want to talk about it. And then in 15 minutes, we can sort of get the point across. Next question that someone asked, if a doctor wants to make changes in the program, what flexibility is there? And I say there's infinite flexibility. We recommend starting with the full Monty, the full service from BlueStar, and that is the complete hardware, software, equipment, providing all the services, the activation, the monitoring, soup to nuts. Just let us do everything. And the doctor simply has to order RPM for the patient. And if an issue comes up, take care of the patient on a billable basis if the monitoring uncovers some need for additional care. Then, if the doctor decides that he or she wants to do the monitoring in-house, great. There's no long-term requirement that BlueStar does it. If the doctor wants to do all the equipment and then doing the inventory and the shipping and the training and all that other stuff, they can do that too. And if after 6 months they hate the whole thing and just want to quit, they can do that too. Okay, so there's very little long-term obligation in this program. In fact, there's really no long-term obligation. The only obligation is if the doctor, if BlueStar performs a service and then the doctor bills CMS for that and gets reimbursed, we would expect to be paid that. But if the doctor says, that's it, I'm all my RPM, I hate it, away. So I can't think of a program that has more flexibility than this. If a doctor signs up to buy a $50,000 piece of equipment and then hates it 4 months later, you can't send the equipment back. So in this case, there's no upfront investment and no long-term obligation. Someone said, how do we set up an appointment with you, Rob, to do a sales presentation? For right now, just email me. And if you need me in tomorrow or several days out, email is best. If something came up today and there was some opening at 4 o'clock this afternoon, try texting me or calling me, but don't assume that I have my phone with me all the time. And frankly, I get so many calls every day from numbers I don't know. I typically don't tend to answer numbers that I don't know. That's why I'm trying to put all of the numbers into my phone. When in doubt, call our 800 number for BlueStar, and the customer service people will know where I am and what I'm doing. And just say, hey, I'm helping to sell RPM and I need him to be in a sales appointment. Where is he? They'll be able to find him. And then we think that eventually we're probably going to institute a Calendly system where you can go in and you'll actually see what my availabilities are, and then you can pick a time. So for the time being, let's just go with old-fashioned email. Someone said, how much will it take for me to make 100K annually? And so I'm a nuke and it's just math. And so here's my short math. Assume that the representative is making $7 a month per enrolled RPM patient. Okay. Then to make $100,000 a year, that would be $8,300 a month. So that would be about 1,200 RPM patients. So the question is, how do you get 1,200 RPM patients? Well, you could do 6 practices at 200 patients, or 12 practices at 100 patients, or 24 practices at 50 patients, or 2 practices at 600 patients. You guys can all divide 1,200 by other numbers as you see fit. And I think that these are very doable things. Imagine if you went to a practice that had, say, between 5 and 8 clinicians. They might have 5 or 8,000 patients. They might have 2,500 Medicare patients. And if 10% of their Medicare patients were a fit for RPM, that's 200 patients right there. And that's one of your 6 practices. So do the math and make your decisions accordingly. Someone said, Rob, after I make the sale, do you want me to stay in the relationship with the practice? And the answer is yes. This is sort of a variant of a previous question from a different rep. The sale is only the start. You can sign a doctor up and he or she can become capable of ordering RPM, but then they might need some continued attention because you want their RPM numbers, the number of patients enrolled, to go up. And so, yeah, absolutely, we want you to stay involved. That's why we want to continue to pay an ongoing commission. Could we sell this into home care groups or in other places where the patient pays? This was someone who emailed in her question because I wasn't sure if she was going to be on the call today. And the question is, if you're dealing with Comfort Keepers or Right at Home or some kind of a home care agency, could they sell it? The answer is yes and no. Of course they can sell it. And BlueStar will happily provide all of the same services. Um, and and the family can pay, or the home care franchise can pay. However, BlueStar doesn't have doctors and we're not the clinical caregivers. So we could install equipment for which the customer paid. We could do the software for which the customer paid. We could do the monitoring, and then our nursing staff would report back, probably not to the franchisees, probably directly to the family that was doing the paying. So the answer is yes, we can do it on a private pay, non-reimbursable basis. Just got to remember that there's no doctor involved there. And unless the family doctor is the one that's notified. And if there's a family doctor that wants RPM, then the family doctor could just order the RPM and the family wouldn't have to pay. So this is a little bit of a complicated issue when you get into who's paying for what in home care. And home care is different from home health care. So when in doubt, talk to me. And I hope I haven't muddled the answer too badly here. Is RPM covered by Medicaid? As you know, Medicare has a national plan, and you can go to a single national website. And if I were more organized, I would put the link on here. Care reimbursement for your particular location, because it's set federally. Then Medicare Advantage is a local version of Medicare, and it typically covers RPM, but the individual Medicare Advantage provider has to set their own rules. So right now, for instance, in Louisiana, there's 3 or 4 major Medicare Advantage plans, one of which is Humana. I can look up on the national website what Medicare pays for RPM in Louisiana, but I'd have to go to the Medicare Advantage site to figure out how much they reimburse for RPM, or if they reimburse at all. And that's hard to do. Typically, we have to go through a provider. So I'm almost to the answer here. For Medicaid, it's up to the individual state. And I feel bad because I do not yet have an individual state-by-state lookup list. Some states reimburse for RPM, some do not. Some reimburse at close to Medicare rates site. And then for our BlueStar team, we'll add to our to-do list to come up with the state-by-state list. And any more questions? So now I'm going to, we have had several questions come in. One said, neurologists might be a good market with Parkinson's patients as they are on multiple meds that impact vitals. Okay, so that's a good point. And I said maybe neurologists are not a good fit, but I could see how that would be, Parkinson's patients would be a fit. All in all, if I could go down the street to a neurologist practice or to a general practice, I'd probably choose general practice. Rick Warren said behavioral health is served through the telehealth function. Okay, Rick, I'm going to ask you to talk about that in a minute. Someone said, can an NP order, thinking of an NP run practice, a nurse practitioner who visits, manages geriatric patients in assisting or independent living facilities or in their own homes, but they do not see doctors? And the answer is yes, nurse practitioners can order RPM. Another question, can a provider customize what they want monitored or updated on? And another good question, and the answer is absolutely yes. So we have a standard protocol which lists how our monitoring staff will monitor patients. And it's a standard template, and it talks about what we're going to be monitoring and what the specs are and how often we monitor and when we send reports and how we send reports and what's red and yellow and green and when we call 911 and when we don't. It's a 6 or 7 page document. And we give that to the client, and then the client amends it as they see fit, and they edit it, and then they sign it. Because our monitoring staff, they are qualified healthcare professionals operating under the clinical supervision of the provider. And so we have to do what the provider says, so they can customize it exactly how they want it to be. Okay. I got this one and that one. Okay, Kevin Rowlandson says nurse practitioners can only bill 85% of what a doc bills, so they make 15% less. Okay, I'm going to write that down and find out, because we are dealing with a client that has doctors and nurse practitioners, and those nurse practitioners are the ones ordering the RPM, and they're being paid at the full rate. So I don't know if that's during this emergency procedure, or if they're writing a script and then the larger clinical team is billing for it. I'm not sure. So I'm going to find out about the 85% for NP rule. All right, sorry, I'm making notes. Here's another question. Any ideas on how to get the attention of the provider when sending the email it was suggested we send out? Catchy subject line in the hopes it doesn't get ignored. There's an entire science on getting emails to be paid attention to, as you know. If you go into Google and type in the top 100 email subject lines of 2000 or 2020, you'll see lists of email subject lines that get people to pay attention. You have to be careful because you don't want it to be stupid. My view is it's going to take multiple emails, and you're going to have to try different things. You know, our goal is to get their attention for 15 minutes. Our goal is do they want to optimize their practice? You can feel free to use Admiral Ray, because people don't often get emails from admirals. And so usually if I'm trying to get someone's attention, I might write as a subject line, query from an admiral or something. And what you're really trying to do is get them to spend 15 minutes with me and you on the phone so that we can talk about it. So no, I do not, or we do not have a proven subject line that we know is going to get you better response. My feeling is I usually start pretty professional, and then as time goes by and I'm re-emailing, I get a little bit either more clever or more desperate, depending on how you're doing it. So as we find something that works, we'll let you know. All right. I answered that live. I'm working through all these questions. Okay, so Kevin said if the nurse practitioners are getting 100%, they're probably going through the doc. And his point is a solo practice nurse practitioner will not have the 100% reimbursement. So again, I've written it on my list, and next week I'll make sure that I put out the word. Okay, hang on. Let me see, there's more questions coming in. Here's one. I'd like to schedule a webinar with my client for purchasing the equipment with self-pay for non-medical. And so I'm happy to talk to you and get a hold of me on email, and we'll set something up. We've had a couple of people say, Rob, can you do a webinar for a group of doctors? And the answer is absolutely yes. And so if you individually or your rep group that you're in want me to get on a webinar, we can just make it be about telehealth, or we could make it be about leadership lessons from Baghdad, which might be more interesting for people, or leadership 7 lessons I learned in Baghdad about how to make your practice better. There's lots of things we can do with webinars and Zooms. Okay, any other questions? And I might open the floor to Rick Warren so he can talk about behavioral health through the telehealth function. Let me see, hang on. I got those questions. Forgive me, guys. I got all these things coming on and I'm trying to manage it. All right, So hang on, Rick. I'm going to try to bring you in. Okay, Rick Warren, are you there, sir?
I am. How are you, Admiral?
Okay, we can hear you, buddy. So tell us more about the telehealth and behavioral health function, please,
Well,
in
the
Vital Tech.
yeah, the entire spectrum of behavioral health services are delivered by telehealth today. So and telehealth is a subset of vital care RPM. So if you have someone who's interested in behavioral health, we can serve. They can serve their clients uh, using the telehealth portal within Vital Care, and can bill for it with respective codes. I can't tell you what those codes off the top of my head, Rob, but I'll go ahead and give you those so you can take a look at those. It's just an opportunity to expand the interest, and we're doing it in Arizona.
Okay,
right now.
so let me repeat what you said so I can make sure I'm getting it right for the benefit of our listening audience. And that is, once you've established the vital care connection with a patient, which gives you the opportunity for a video interface with that patient, then you can do behavioral health things through that connection, correct?
That's correct.
And you can bill for them. However, my question was, RPM, remote patient monitoring, you can do remote patient monitoring for obesity or diabetes or hypertension or yada, yada, yada. But I'm unaware of a way to do remote patient monitoring for behavioral health.
It falls outside of RPM,
Okay,
but it is still within the capabilities of the platform. So my only point in that is that if it's a sticking point where you have to figure out how to serve this behavioral health element within a practice to make the deal, you have the ability to do that via telehealth. All of those things can be delivered or are delivered today virtually.
right. Okay, got it. All right. And that's one of the things that I'm constantly saying to doctors, and that is, look, establish that telehealth relationship and let RPM pay for it. And then all the things that you do with it are completely free, because there's no more charges, obviously, for the system. Once the system is in, then you have a HIPAA compliant tablet in Mrs. Smith's dining room, and it's got your name on it, and use it as much as you can to have interactions with Mrs. Smith, which is to her benefit and to yours. Okay, anything else to add there, Rick, before I press this button and mute you again?
Roger, over.
Okay, thanks. Now I just have to find your name. Again, I'm sort of I'm not used to operating the connections at my multiple user thing here. All right. Mark Iavino, one of our other Vital Tech experts. Are you on the line?
Can you hear me now?
Mark? Yes, I can hear you now. Mark, do you have anything to add, or is there anything that I've covered in this Q&A in the past 20 minutes that needs to be corrected by someone more expert than me?
No, I think you pretty much covered it. There was that slide about nursing homes, and typically nursing homes are paid a flat capitated fee for the residents that they have, in their facility. So doing RPM and billing for it for fee for service doesn't typically work for them. But where it does work is that it enables them to provide better care, hopefully reduce patients who are being readmitted to the hospital. So there's a way that they can save the hospital system money by reducing the number of patients that are readmitted to the hospital within a short period of time, costing the hospital money. So nursing homes are trying to work with hospitals and saying, look, if we can reduce our readmission rates and save you guys X number of dollars a year, is there a way we can share in that savings? But in terms of most nursing homes, we have other people in our company that are more, they just know more about how to do a capitated account, like hospitals and nursing homes and skilled nursing facilities. I'm basically focusing primarily on the private practice, which is all fee for service. So it may be something that Rick could add to, or we have a gentleman by the name of Mike Webster, which would have some more information on that. But I think for everybody on the call, focusing on the physician market is really where you need to spend your time.
Okay, great. Thanks, Mark. Appreciate your expertise as always. I'm going to mute you and then go back to another question or two that's come in, and then we'll probably wrap in about 5 minutes. So someone wrote in and said, so potentially a patient could use the telehealth function or a physician could use the telehealth function, monitor the patient's ADLs or activities for daily living, maybe have them log in every day to monitor their mental health, maybe logging their mood, etc. And my understanding is that all that's good stuff, but it can't be reimbursed under RPM, at least not under the current rules. My understanding of the current rules is you have to have a device which is measuring a physiological parameter and delivering that medical data to a caregiver. And so having the patient log in and say, today I'm a 7 out of 10 and this is why, is good stuff. And it could be used as part of a behavioral health or mental health program, but it's not reimbursable under RPM as I understand it. So it's a little bit, once again, then this is a great way for a doctor to establish a relationship with the patient. For instance, a doctor could say, you know what, BlueStar, we want you to come in, install all this equipment. We'll use the very cool VitalTech software, and we're going to use it just for behavioral health. We're going to do psychiatry over the phone, and we're going to use the system, and we're going to bill for telehealth events with our patients. That'd be perfectly fine, and we would be happy to support that. And it works mathematically as long as they're billing for something, but it's not RPM. So I'm not saying we won't do it. I'm just saying it doesn't fit into the rubric of the RPM, which isn't currently designed to do mental health monitoring. It could, if someone's hypertension were being monitored, that would be RPM. And then the doctor could use that system to conduct mental health visits or to log in for mood and all that other stuff. But if you're only doing the mental health, the behavioral, the mood, all those things, then you have to bill under different under different CPT codes, as Rick Warren pointed out. And which is fine. It just ain't RPM. Okay. So I feel like I've probably talked about that longer than I should have. So that's all I have, folks. Does anybody have any questions before we wrap? My goal is to be frugal with your time, and so I don't want to extend this any longer than we have to. I'd rather we spoke frequently for half an hour a week. And when new questions come up, keep those cards and letters coming, and we'll try to cover them this way. And in coming weeks, we'll get into other topics. In the meantime, I'm always available. Please get a hold of me and get a hold of our BlueStar team. You know, our Chief Operating Officer is Admiral Gordon Russell, and we have several account managers. We have a customer service staff. We have a tech support staff. We have the experts at VitalTech, like Mark Iovino and Rick Warren and Mike Webster. So we have reach back when you need it. Just let us know. And obviously we want to make you successful, so we will do just about anything we can to do that. Okay, so with that, I'm going to let you go and say thank you very much for joining us in our inaugural weekly webinar. And we'll see some of you next week. Okay, thanks.
Thanks, Rob.
All right, see ya.